So let's start with the causes of cirrhosis, starting with alcoholic liver disease. So alcoholic liver disease is when the person is consuming more than 20 gram of alcohol per day in women or more than 30 gram of alcohol per day in men. So this persistent consumption of alcohol on a daily routine basis is going to affect the liver. So starting with triglyceride metabolism. So when alcohol is being consumed, alcohol will be metabolized into acetaldehyde by the enzyme alcohol dehydrogenase. So after this, the acetaldehyde will then convert into acetate by the enzyme aldehyde dehydrogenase. So during both of these reactions, NAD is going to be utilized and NADH is going to be released. So this released NADH is going to enter into the lipid biosynthesis. So this is going to be used in the synthesis for lipids. So this lipid metabolism is going to be grossly altered. So even peripheral catabolism will be there and lipid biosynthesis will also be there. So the altered lipid biosynthesis will result in the first stage of alcoholic liver disease called as steatosis. Okay, so steatosis is nothing but accumulation of triglyceride in the hepatocytes. So these triglycerides initially will be forming small vacuoles. So in this image, if you see, like in this, there is small vacuoles inside the hepatocytes. So these small vacuolar hepatocytic degeneration is called as steatosis, which is microvesicular. So microvesicular steatosis is multiple small vacuoles. While these things which look just like an adipocyte, right? So the entire cell is filled with this vacuole pushing the nucleus to the periphery. So this kind of steatosis is called as macrovesicular steatosis. So microvesicular steatosis can progress on to macrovesicular steatosis, and classically alcoholic liver disease starts in zone 3, that is the centrilobular zone. Then other than that, this acetaldehyde, it is going to be a toxic metabolite. So this toxic metabolite can cause various reactive oxygen species formation, which will in turn cause lipid peroxidation, and the harmful effects of reactive oxygen species is going to happen. Other than that, alcohol is also directly toxic to the various organs and the mitochondria is going to be heavily damaged by the alcohol. So because of this, there is going to be lots of symptoms and signs related to this alcoholic liver disease. So the second stage of alcoholic liver disease will be hepatitis. So inflammation has started happening in the hepatic parenchyma now, and this will result in ballooning degeneration. The hepatocytes are getting degenerated. Along with that, you can see neutrophilic infiltration. So neutrophilic infiltrates will be present. So this cell is undergoing the ballooning degeneration here. And I can also see the presence of Mallory-Denk bodies. These are also called as Mallory-Hyalin bodies or alcoholic hyalin. So these, even though it is a non-specific feature, it can be seen in many other liver conditions as well. But the maximum number of Mallory-Denk bodies are seen in alcoholic liver disease. So what are these Mallory-Denk bodies? So these are nothing but these eosinophilic amorphous inclusion-like substances inside the hepatocytes. So these are actually composed of intermediate filaments like cytokeratin, especially cytokeratin 8 and 18. So this is a very important question. Mallory-Denk bodies are seen in alcoholic liver disease, and it is composed of intermediate filaments, cytokeratin 8 and 18. And you can also see megamitochondria. Since mitochondria is the one which is being grossly affected by the alcohol, it is going to result in the formation of megamitochondria, which we can appreciate on a electron microscopy. So the third stage of alcoholic liver disease is the cirrhotic stage. So in cirrhosis, this alcoholic cirrhosis is specifically given a name called as Lennox cirrhosis. So Lennox cirrhosis, it will be initially micronodular. Later on, it will proceed on to a macronodular cirrhosis. So this is a Mason's trichrome stain used to demonstrate the fibrous septae, which is composed of the collagen, which is forming these nodules of hepatocytes. So these nodules of hepatocytes are seen, right? So in between this blue colored thing is all the fibrous septae. So classically, the alcoholic cirrhosis has been referred to as micronodular cirrhosis, which is less than 3 millimeter in size. The nodule size will be less than 3 millimeter. So multiple nodules will be there, and each of these nodules is going to be less than 3 millimeter. But in later stages, they can become increased in size, that is more than 3 millimeter, and they are going to be called as macronodular cirrhosis. So cirrhotic liver, if you see, this is the classical image of a cirrhotic liver, be it any other cause also. So you see multiple studded nodules on this, and it's a diffuse process involving the entire liver. And being a cirrhotic cause, the alcoholic liver disease has an increased risk of hepatocellular carcinoma. Then we'll move on to the next disease, which is non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease is going to have the same features as an alcoholic liver disease only, but only thing is there will be very less consumption of alcohol, or there will be no consumption. And classically, these patients will have metabolic syndrome. So in this, the patients will be obese and they'll have diabetes, hypertension, hyperlipidemia, insulin resistance. So all of this constitute the metabolic syndrome. So metabolic syndrome X can present with NAFLD. And the stages of the liver disease is also the same as alcoholic liver disease, that is steatosis, then hepatitis, which is called as non-alcoholic steatohepatitis NASH, and then cirrhosis stage. And one important feature of distinguishing between this alcoholic and non-alcoholic fatty liver disease is the ratio between aspartate aminotransferase and alanine aminotransferase. So AST to ALT ratio will be more than 2 in alcoholic liver disease, while it is going to be less than 1 in non-alcoholic fatty liver disease. Again here, NAFLD has an increased risk of getting transformed into a hepatocellular carcinoma. Then we'll see about the third disease, which is alpha-1 antitrypsin deficiency. So about alpha-1 antitrypsin deficiency, we had already seen in lung chapter, right? So respiratory system discussion. So this is an enzyme deficiency. So automatically it will be a autosomal recessive pattern of inheritance. So this patients, and alpha-1 antitrypsin is actually a protease inhibitor, right? So this protease inhibitor, so this will be responsible for degrading the elastase enzymes and other enzymes which are protease enzymes which are produced by the neutrophils. So when this protease inhibitor is going to be deficient, there is going to be uncontrolled elastase activity, which is going to result in pan-acinar emphysema in the lung. So along with that, in the liver, it can cause a liver disease. So the normal protein is going to be having this PIMM phenotype. So after this PIMM, when it is going to be having a deficient status, it is going to be represented as PIZZ. Since only homozygous state can present in a autosomal recessive condition, so it has to be PIZZ. While a PIZM is also there, which is a heterozygous state, and this will not have the classical features of alpha-1 antitrypsin deficiency. So it is going to be PIZZ homozygous state, which is going to cause the disease. So the disease actually happens as a result of misfolding. So alpha-1 antitrypsin, when it is being produced, during its folding, it is going to be misfolded, and misfolded proteins will be degraded by apoptosis. So it will be lost. So there is going to be deficiency of alpha-1 antitrypsin. And here again, there is going to be increased risk of hepatocellular carcinoma. So on liver microscopy, if you see, it is going to have these multiple eosinophilic globules composed of this alpha-1 antitrypsin. So these are all the hepatocytes, and inside the hepatocytes also you can see this presence of eosinophilic cytoplasmic globules, especially in the periportal area. And these globules are going to be periodic acid shift positivity and diastase resistance. So past positive diastase resistant globules are seen in this alpha-1 antitrypsin deficiency. So in the question, when they are mentioning about a 30 to 20 to 40-year-old person who is presenting with a lung disease along with a liver disease, and they give such an image, this histopathological image, then immediately you'll have to think about alpha-1 antitrypsin deficiency.